All right, let's get started. Hi, everyone. I'm Allison Bond, the Director of Grand Rounds, and I'm really excited to introduce our guest today from the world of surgery. Not often that we have a surgeon here at Medicine Grand Rounds, but very excited to learn from Dr. Adnan Alseidi, who's a professor of surgery here at UCSF. And accreditation here. He was the past president of the Association for Surgical Education and has had numerous leadership roles in the Society of American GI and Endoscopic Surgery, for example. And then in his wearing his educational hat, his work aims to advance assessment systems, accreditation, and the integration of innovation and AI into med ed and clinical skills training. Thank you.
Thank you. Thank you so much, Dr. Bond. It's a pleasure to be here. I'm looking forward to it and looking forward to a good discussion. As Dr. Bond said, I'm going to focus on psychomotor training and procedural skills and how that's changing. I do teach courses for liver surgery but no conflicts applicable here. So I'll try to have this a little bit more of a big picture talk that actually is going to focus on what is really changing in procedural medicine, especially with respect to assessment and training. And I really want to focus on this not just for the trainees, but also for the faculty as well. And of course, medicine is no stranger to procedures, right? You all have a ton of procedures that you all do. So there's a lot of overlap here. And I don't want this by any means to sound like this is a surgical talk. This is really about psychomotor training and assessment training, and I'll focus it on that. So there's a lot. But in the world that is changing quite rapidly, where you can literally take a picture from space with an iPhone that actually shows the backside of the moon and Earth in the distance, it's really not a question of like, why should I care about this topic, especially if you're not, even if you're not in surgery, or even if you don't do procedures. It's really the question of like, why not should I care about this topic? Because everything is changing. The definition of competence is changing. The definition of what actually is a physician is changing, and we'll talk a little bit about that, but I don't have to say that really to a group that, you know, I'm sure Dr. Walker has drilled that down with all the stuff that he is publishing. But I can take a picture like that that's taken by an iPhone and actually put it into a software, and within minutes, not only do I know everything, all the name, geography of the moon, but also know exactly why each one is named. And so everything has changed, and that's what I'm hoping to focus on today in the sense of like, why is procedural medicine changing? Now, before we do that though, I'd like to make sure that we are all on the same page in terms of like, what does it actually mean to actually get assessment, all right? So I'm just going to show you a quick Prezi that actually kind of divides that. And the whole idea here is for our GME and CME is that the whole point of a residency, for example, is to go from novice to competence. And then, you know, the road gets very bumpy because basically we unleash people on the world, and even if they do a fellowship here, and then basically you're going to go to what's called proficiency and expertise. And the question is, how does somebody progress on this spectrum safely? And it really becomes a very easy question to say, like, how do we learn? And it sounds like a very easy question, but unfortunately, there's very complicated answers. But it comes down to three things. There's interactive teaching, which we could talk about all day. There's active learning, which means that a person is an adult learner, which is also something you could talk about a lot. But what I'm going to focus on is the third pillar of learning, which is formative feedback, formative assessment. And the idea is that you don't learn if all you get is what we call assessment of learning. You really need to focus on assessment as learning and assessment for learning. And this is what has really, really changed a lot in procedural medicine in the last even 5 years. And I hope to show you some of the examples, even in complex surgery, let alone non-complex procedures in surgery. And the idea here is, in the end, it's all about trust. How do we actually get to a point that we trust that somebody is safe to do a procedure? And this is different than saying competence. And there's the differences, and we'll talk a little bit about the definition of the ingredients of entrustment, which means that even to a point where it means that you can actually be not competent in taking care of all types of procedures, of all types of variations of that procedure, yet still be entrusted. So think about it like if you are putting in a central line, you may not be actually competent in putting in a central line in somebody who has on dialysis and has hypertension or varicosities, but you know that your limitations and you know how to ask for help, and so you become entrusted even if you're not necessarily competent to all the variations. And so the road to competence is based on feedback, and this is what really we're going to focus on today. But then there's the other side of it, which is really what a lot of learners focus on, which is like, am I going to graduate or not? Or am I competent or not? And the idea of figuring out how somebody has achieved competence is also a type of assessment. But this assessment is very different than the assessment of for learning. And the idea here is if we're saying whether it's skills or cognition or behavioral attitudes, all of this requires different types of assessment tools for us to say that somebody has achieved competence or not. And so this is where, when we are looking at skills, we're really mostly focusing on entrustment. And I'll come back to this graph in a little bit. The idea is that the ingredient of trust is very different than competence itself. But the point is, when we look at our all three domains, we should be able to say you're below competence, you're competent, or you're not. But the whole point of feedback, the whole point of learning doesn't stop when you graduate, right? And so this is where a lot of people struggle as junior faculty and mid-career faculty. And the idea here is that if you say proficiency, which is where a lot of people get stuck, and that is the idea of you're actually looking at things holistically, especially procedures, you're able to accommodate for changes. This is, we're good at getting people there. But the question is, how do we get them to expertise? And this is where VBA, video-based assessment, has become cheaper and more available and easier and safer and more valid than ever before. Deliberate practice has also become easier, and I'm hopeful to convince you of that and show you that. The challenge becomes when progression from proficiency to expertise, and this is where a lot of the work of Erickson shows that a lot of early career faculty and mid-career faculty exhibit something called arrested development. And this is because of lack of coaching, lack of cognitive task analysis, hierarchical task analysis, and near miss training. And this is something that happens a lot in high stakes fields, but doesn't happen in medicine. And so this is what happens. Instead of achieving expertise, you get this truncated arrested development. And we actually pride ourselves in optimism, where basically you're saying, oh, I can drive from home to work without thinking of the stoplights, without thinking. So I'm automatic in that sense. And that's a good thing to a point. Atomicity is actually shows that you've accomplished some competence and skill, but it's also a negative fact for achieving expertise. And so if we go back to the talk, so that's the kind of like the big picture. But the point is, feedback is literally all across this whole place. You need feedback to progress from novice to competence. You need feedback to go from competence to proficiency, and then you absolutely need feedback, and you need assessments to go to expertise. And all of this has basically been the changing because of the world of technology and AI. And so that's what we're going to focus on. The second two parts of my talk, I'm going to focus on this, the world of simulation and how that's changed. And then we'll talk lastly about AI. And I'm hopeful then we can have a good discussion. And all of those things overlap. But if you look at entrustment, and that's a key point, because entrustment allows you to actually achieve autonomy even when you don't have full competence in things. There's basically four parts to it. There's what we call in the environment, educational environment, safety, psychological safety environment, circumstances. That's really important, and that's key. There's the patient, and I emphasize that because especially in places like Parnassus, most patients that come here are not quote unquote bread and butter patients. You get a lot of complex patients. And so how can you achieve autonomy in situations where the patients are transferred by competent physicians to here? And so how can you be, in that scenario, how can you do it? And it's an important question, but it is doable. And at the moment we think, oh, patients are too sick because they're too complicated, is the moment that we basically are saying all training should happen in community hospitals and not in places like here. So it doesn't make sense. So I think that is an issue that we need to address, but it's not a showstopper in my mind. Then there's the issue of faculty, and we really, really push the faculty development quite a bit. But at the same time, a lot of times we think that that's the only problem that we got to fix. But actually, the truth is that often the faculty development is secondary to a system that is not preparing learners to learn. And this is what I want to focus on, is actually how do we get learners prepared to learn? So I'll focus on that learning factor more than anything else today. And so let me give you an example from surgery, but this is actually true in all procedural medicine. So if you go back 20 years, not that long, and say, let's compare two surgeries that have nothing to do with each other, a left colon and a AAA, an abdominal aneurysm. They basically shared the same exposure, midline incision, the same retractors, the same anesthesia, the same instruments, really very little technology. And so you can literally learn about 40% of a AAA and never done a AAA. You can learn maybe 80% of a left colon and never have done a left colon. And the amount of cognitive load when you go into the operating room is very low because everything looks familiar. It's the same anesthesia, the same setup, same everything. Look at what has happened to these two surgeries since then. AAA now, the patients, I used to say they still share anesthesia, but they don't even put these patients to sleep anymore. They do them under constant sedation and local. It's all about cone beam CT, all about wires and stents and fluoroscopy and ultrasound. And a left colon, the surgeon is not even touching the patient. They're on a robot. And so my point being is not only have they completely diverged and there's very little cross-training and cross-learning from both, but also the amount of technology in each have exploded. And so if you think about that, and you can talk about this in almost any procedure, even like an A-line. We're now an A-line with an ultrasound. And so what's happening is that even simple procedures have basically now become much more complicated in the past, whether it's because of technology or whether it's because of data science or whether it's because of imaging or the patients are sicker. And we used to not do, like I'm a cancer surgeon, we used to not resect patients if they were, obese or locally advanced. And now we resect all these patients and we've actually shown benefit. So everything has gotten more complicated and even simple stuff. So this is, I help run, I used to be the president of the Fellowship Council, which trains people for different types of fellowships. And these are the fellows in the United States. And you could see robotics for inguinal hernia. This is direct, simple, straightforward inguinal hernia. Robotics is exploding and laparoscopy is decreasing. The point being is even simple stuff is getting complicated. And this trend is not getting better. It's getting not necessarily worse. It's not getting lighter. This trend of data science infused into our world is getting more and more. And the idea here is that in the future, we're going to be basically dealing with an incredible amount of data, and procedures have never been intuition only and probably will never be data only, but that pendulum is swinging quite a bit. And just from a point of cognitive load, if you can think of a human brain as a cup, and there's only so much you can learn. If you actually overwhelm that active memory, at that point, they're just basically staring at you. They're like, I don't know where to go next, because there's just so much to learn. And it's just to learn how to put a central line with and use ultrasound and use this and this and this. All of that complicates things. And so how can we actually change this and this aggressive cycle to actually be for our benefit instead of for our detriment? And there's a quote that I really like to always remember, is that just because this is how we were taught in the past doesn't mean it's the right thing for us to teach in the future. And this is where we've really kind of adopted this very aggressively in surgery. And that if you look at how you actually learn procedures, there's different stages. There's conceptualization, understanding the need, the indications, the counterindications, visualization, verbalization. This is where you actually see a procedure and you are able to verbalize the steps. These are important steps. We do okay with the first one. We do not okay in the second two, because most learners, when they want to know how to do something, the first thing they go to is they go to a YouTube or Vimeo. And we know that there are actually multiple studies showing that the public domain videos are incredibly unsafe. Despite the millions of likes and thumbs ups and all that stuff. But the key here is technology now can help us specifically with this, practice and reinforcement. And we know that procedural medicine is really key on deliberate practice. And so that's what I'm going to focus on today. So with that was a very long preamble, sorry about that. So now I'm going to talk about what we have done to actually help this idea of actually actually getting people ready. So when they actually step into the operating room, step in to do a procedure, they're no longer learning the basics. They're no longer doing this stuff here. They're actually focusing on true practice, but getting feedback. And the point here is that simulation has actually been there for a long time. The problem is simulation has failed in so many different residencies and practice and faculty, and even with faculty, mostly because we usually focus on one or two of the three pillars of simulation. And the first is you need to be able to simulate from somewhere. You need hardware, you need software. But now most of our simulation happens, as you will see, with really your own smartphone. And I'll show you that in a second. And it's very, very cheap now to do this. The other thing is you need a training program. In the past, people would do something and actually there's no stepwise progression. And now we have really easy and free training programs. And lastly, and probably the Achilles heel of most simulation in the past, is that you need to be able to give feedback to the people who are simulating. And this is where it's been a really big problem, because you tell faculty, I want you in the sim lab, or I want you in giving feedback to somebody. And the chances that they would do that the first week is probably like 10%. And then the second week is 8%. And then it just goes to zero. And so how do you solve this problem? And this is where I always say everything in the world is getting more complicated and more expensive. But this is actually getting cheaper and easier and actually more valid, more precise, I should say, instead of valid. So our three pillars of the simulation center is, the first is we actually have these very easy, cheap, durable simulation labs. And this is for major surgery, and as I'll show you, but for procedures, you even have cheaper simulators. And this basically is a TV screen that we buy from Costco, and a box that actually lasts forever. And the whole thing costs like $3,000-$4,000 and actually basically lasts forever. The point is that this resident is using their iPhone to upload all their images. They follow a curriculum. We have curricula for basic laparoscopy, advanced laparoscopy, robotics. We have curricula for everything. And then it all goes up to the cloud. They get asynchronous feedback. They get AI-based feedback. And then they progress on their steps going forward until the point where they're ready for faculty feedback. And even that is now, we're replacing that with trained senior residents and fellows. And it's incredible how you can achieve really strong competence. I don't actually know if I actually showed, I didn't put out that slide, but we have now published data to show that I can get interns before they even do the same procedure in the operating room to actually be as proficient in doing things like side-to-side anastomosis or complex intra-abdominal surgeries as bariatric surgeons. In other words, better than general surgeons to a level of bariatric surgeons. And the point behind this is to say they're obviously not ready to do that on humans, but the point is that they go into the operating room and they're not going to struggle with the instruments. They're not going to struggle. They're not going to get overwhelmed with the environment, and they're ready to actually practice. This is a paper that we've published on this just as a reference. But here's an example. This is one of our residents doing a side-to-side anastomosis. This is something that he's doing on his own. There's no faculty at the lab. It goes up to the cloud directly. They get AI-based feedback, and then one of their peers is looking at this and actually tagging best. One peer that's already finished that curriculum, tagging best practice videos, which are already part of the library, for them to actually see what they could do better. And they just so they're getting this asynchronous feedback, and you can even gamify this. So you'll see in a little bit. You could put this sign like, I know who told you to do that, don't do that again. And so then they get that on their phone. And so they get on their phone, they can, as they can see that they passed one and they failed one, they have to repeat it. They get verbal feedback, they get annotation on the screen. And so the point being is that they can actually progress. I'm just gonna fast forward this to show you what they're getting. And that they can progress without necessarily waiting for that faculty. And so this has actually been so helpful for us that we've gotten to a point now that we actually have a rotation that's just in the simulation lab. So our residents from 8 to 5, that's all they do. They have no clinical expertise, and this is kind of where they go through in the whole month. They do all the robotic simulation, laparoscopic simulation, energy simulation, endoscopy simulation, and the point being is when they finish this, they're incredibly comfortable to go to the operating room, whether it doesn't matter what modality is happening. And this is how they start, for example. This is just to teach them how to actually be comfortable with muscle memory with respect to instruments. And as you can imagine, you can create a curriculum for almost anything. In fact, we noticed after we did this that a lot of the struggle in the operating room was because was transferring to open surgery, and that's because a lot of the simple stuff was all going to laparoscopic and robotic, and all the crazy complicated stuff was open, but they didn't really have the benefit of open surgery to practice and get comfortable. So they were becoming uncomfortable with open surgery. So we created a curriculum for advanced open skills. And this is the same thing here. The same idea is that this is using 5.0 and 6.0 sutures. This is really small sutures. As you can see, she's using her phone to upload her images. So I just happened to be in the lab that day, but they don't need me in the lab. And they're basically just suturing, and it uploads to the phone, to the cloud. They get feedback. And once they achieve that level of competence, then they go to a more complex skill. This is a 3D plastic model that costs $15 of a pelvis, and now it's a deep suturing, so doing the same thing but for deep suturing. And so that's how we progress. And the AI gives them feedback to the point where, as you can see here, the student is the resident is the orange, and then the black is the attending, and the fellow is the blue. And they keep drilling until their numbers match the fellow and the attending. And so obviously that basically means that when they go to the operating room, they're not going to be, getting feedback on like how to hold a suture, how to actually, because that's all basic and that's all drilled in with feedback through the curriculum. And so then they get to a point where they're ready to actually learn the procedure as opposed to learning the technology, if you will, in the operating room. And this can actually progress to a point where we take the same 3D model, use a pig kidney, a pig aorta, and actually simulate an entire renal transplant in the skills lab. So in this case, he's a first year, she's the third year, so she's doing her teaching curriculum, and he's gonna then practice. And then the person that's watching both of them is a coach, and so that's a senior resident. So they're going through their coaching curriculum. So it's kind of like a little bit more of a loop. There's like 3 curricula going on at the same time, and that just maximizes the time of everyone in the lab. So again, all of this is happening in the lab as they're drilling. We've done the same thing for robotics. UCSF is very keen on developing the robotics lines. As you can see, all of these lines this is not all general surgery, but there's 13 or 14 lines of robotics that are happening in UCSF. And so we need to make sure that our residents are going to the operating room ready to actually use the robots. And so this is the interns' incoming week when they first start. As you can see, there's robotic training from week 1. And then they go through their simulation, the console simulation, the bedside simulation, the sim AI, and it gets to a point where they come to the operating room ready to actually use the robot. So I'll give you an example. This is a week 9 resident. So she did her first month was ICU. Her second month was in simulation lab. So she comes into my operating room on week 9 of her 5-year residency. And her first comment was, I've done all my bedside, I've done all my simulation, my simulator simulation, I've done my console, I'm ready for the console, I'm ready to be the surgeon. So of course, that she puts, considering I always talk to them about how important it is for them to be more proactive with the faculty. Of course, at this point, I couldn't say anything. And so this is her as a week 9, using the robot to do a gallbladder. And of course, there's a lot for her to learn here, but at least I know that she's safe on the robot. Typical, just to give you an idea, in the United States, people don't go on the console and robot until year 3. And so you can expedite all of this by, again, getting this out of the OR into whatever you can get out of the OR into the simulation lab. And so the same thing applies for a lot of procedures that may be simpler for sure. So with that, I want to take a moment to talk about the changing world of AI and how this is actually really helping us understand not only improve learning, but actually improve faculty achieving competence and then also improve our patient care. So that's going to be the last part of my talk, and hopefully we can have a good discussion. And so a lot of times when we talk about AI, especially with somebody like myself who's very much into education, and we're really talking about computer vision and artificial intelligence and deep learning with respect to learning and learners. But there's a lot here to think about with respect to preoperative care, with respect to intraoperative care or intraprocedural care and postoperative care. So I'm going to mostly talk about computer vision, but just to kind of make sure that we all are grounded, there's different, oh, sorry, let me come back. There's the idea here as artificial intelligence, there's machine learning, and there's deep learning. And remember that machine learning doesn't necessarily mean that there is algorithms that are actually ununderstandable, meaning machine learning could just be really good math. So keep that in mind, because a lot of times people think, well, how do you trust it? There's no reason for you not to trust machine learning if you develop it correctly. And so, but my point being is most of the work that I'm going to show you is mostly computer vision, which is a combination of machine learning and artificial intelligence. And the idea that we're using mostly supervised learning, but we also use reinforcement learning. And now I'll explain what all of that is in a second. So computer vision is a little bit more, it's a field of medicine, of AI, that you see a lot in San Francisco because of a lot of different things that is happening around us, but specifically, for example, obviously our automated cars that you see. And the key here is that you're able to take pixels, and obviously it doesn't have to be just pixels from vision. It could be ultrasound, it could be CT scan, it could be radar, LiDAR, any of this, and you can actually then act on them. And so what are we doing with all of this? We're trying to identify things like, where do you dissect? What's safe and unsafe? And how do you identify anatomy for somebody who may actually just be starting using ultrasound? So the key here is that you can use it for learning, you can use it for preoperative care, for intraoperative care, for postoperative care. And so I'll show you first, let's talk about learning. The ability for AI, for computer vision to track instruments is incredibly good. It's probably better than anything else. And so for that reason, we can actually use it for giving people feedback and when they're doing procedures. And how do you do that? Well, we use the same tools, the same standards we've used before. So these are all assessment tools that we use for different things. So GEARS is for endoscopy, GOLS is for laparoscopy, OSATs is for open surgery, GAGES is for robotics. And so these are all really reliable instrument tools that basically all they do is giving feedback on tissue handling, on using of instruments. So now we can replace all of that instead of having actually faculty time, senior learner time, that this is all can be automated with incredible accuracy. In fact, there's a test called Fundamentals of Laparoscopic Surgery that any surgeon has to actually take to be actually credentialed in surgery. And it's called FLS. And we published a paper showing that we can actually, instead of having to pay all this money for somebody to grade our residents and our junior faculty, is that we can literally automate all of this with all these tasks with incredible accuracy. And now we do that. And so now, even though this FLS is actually required for graduating residents, all our first-year residents are FLS certified. And that's because I just put them in the lab and I tell them, keep drilling until the computer tells you you're going to pass FLS, and then take the test and they pass FLS. And so it's that simple because they're getting feedback. You know, there's nothing magical about 5 years. If you have the time to actually drill, you're going to learn this much faster and you're going to be then ready. So all our first years are FLS certified, even though it's not a requirement until you graduate. Now, this is all for learning. Let's talk about how we're using computer vision for preoperative care. So Whipple is pancreaticoduodenectomy, is a resection of the pancreas head for pancreatic adenocarcinoma. It's a big surgery. We do a lot of it here because that's what we specialize in. And the problem with Whipple's is that we have about a 30% positive margin, meaning that the margin where we're taking it off the superior mesenteric artery, the SMA, is actually has some cancer cells on it, which is a very poor prognostic indicator. So what we try to do is we try to give people with high risk of SMA positive margin, we try to give them chemotherapy so that we can actually regress the tumor, sterilize the margin biochemically before we go to the OR. But despite that, we still have about 25 to 30% positive margin. So what we did is we took all the CAT scans of all our CT scans for Whipple's preoperatively, and we basically used reinforcement training to basically tell the computer to look at the tissue around the SMA and to learn how to predict which patients will actually have a positive margin or not, right? And so then after we did that training, we took CAT scans that the computer was never actually trained on, and we had expert radiologists here at UCSF, expert pancreas surgeons here at UCSF, look at a CAT scan and say, what do you think? This person will have a positive margin or not? And then we have the algorithm also do it. And as you could see, whether you look at sensitivity, specificity, accuracy, positive predictive, in every single category, the algorithms was better than the expert pancreas surgeon or expert pancreatologist, radiologist in actually predicting positive margin. Now, why is this important? Because if I know that somebody is going to have a positive margin, or if I think that it's high risk of positive margin, there's other things I could do, like giving them neoadjuvant radiotherapy before going to surgery, or doing an intraoperative resection of a vessel that actually is high risk for positive margin. So this to us is kind of like, right now we're expanding this protocol with UCLA. We just got 320 something of their CAT scans and their data. And so the idea is if we can perfect this, this can become part of our tumor board to say, this person is ready to go to surgery or not. The really exciting thing about computer vision with respect to procedural medicine is that the sky is the limit in what you're studying. So for example, you could study the entire procedure. You could say, I want to look at a cholecystectomy. Or you could say, I want to actually look at the part where the surgeon is getting ready for the procedure to do the cholecystectomy, the preparation. And again, this is all temporal annotated. In other words, nobody needs to go in there and say, I'm going to look at this part. In other words, you could tell the computer, I want you to isolate this part of the procedure from when the trocars come in to the dissection of the cystic triangle. And I want to basically look at that point and look at these factors. And again, now, before, that was incredibly labor intensive. Now it's literally a question you ask at the algorithms and immediately annotates it temporally for you. You can even say, I want you to look at these 400 or 500 cholecystectomies, and I want you to only isolate times where there was bleeding. In fact, you can even say bleeding from the hepatic artery. And now you study that and say, okay, what's causing bleeding from the hepatic artery? Why did the hepatic artery get injured? Again, that's very simple temporal annotation. But we do even more than that. We do what's called semantic or spatial annotation, where we basically say, we want you to look at the instruments and isolate times when a stapler was in the field, and figure out why a stapler was necessary, or when a surgeon clipped. Was there sufficient evidence that they were ready, that they were safe to clip? And imagine that, remember that slide I showed you early on about the VBA for proficiency? Imagine that as data for me as a junior surgeon. Right now, one of the biggest challenges we have in procedural medicine is that our junior faculty get no feedback. The only time they get feedback is when you have a complication and it's presented in M&M. And even that, it's most of the time kind of hearsay. In other words, like, I think I did that, but there's no data to show how the person improves. And it's basically, you improve with trial and error. But this actually gives you data. And the key here is that you can have things like this. This is all gallbladder. This is a paper we published in digital medicine, in Nature Digital Medicine, that basically shows that you can actually annotate all of this, whether you're annotating the gallbladder and the safe and non-safe area, the cystic nodes, the artery, the cystic duct, all of this. And by doing this, now you can actually give feedback to surgeons, and so they can actually learn even beyond their GME learning. I'll show you one more, and I'm going to make sure we have enough time for questions, but I'll show you one more here. This is another paper that we're actually just finishing, and this is for distal pancreatectomy. Now, distal pancreatectomy means that we're transecting the pancreas at the neck, and we're removing we're removing the tail, and sometimes we remove the spleen, sometimes we don't. So this is like a distal pancreaticosplenectomy, this is distal pancreatectomy, and then we're going to preserve the spleen. It depends on the indication. This surgery seems pretty simple, and now we do this mostly laparoscopically, and most of these patients have 4 small holes, and they go home usually within 3 to 4 days, except if they get what we call a post-operative pancreatic fistula, meaning there's a leak here. If they get a fistula, their care completely changes. And this is a paper I just pulled to show you how much studies there have been on this. 43 studies, 21 meta-analysis. If you find anything, 21 meta-analysis, it means it's been studied like crazy, right? Nobody does that many meta-analysis, but this has been a problem. Pancreatic fistula from the stump of the pancreas has been a problem forever. I remember when I was a fellow, and that's now 18 years ago, I remember we published a paper on a randomized study between open and laparoscopic distal pancreatectomies, and they had the equivalent fistula rate. And fistula is a big problem. If you have a fistula, which would classify them as either type A or B or C, in this meta-analysis of meta-analyses, it showed that there were 40% fistula rates. But if you take the complicated ones, type B and C, that you see that they had the patients who have type B and C, which is about 25%, so 1 in 4 patients. Those patients had at least 2 readmissions, had about 4 to 6 GI or IR procedures, had about an average of 3 ER visits, 10% had ICU stay, almost all had delay in chemotherapy, increase in recurrence of cancer, 40K plus increase in cost, and 4 to 5 weeks of IV antibiotics. So by all measures, this is a really bad complication to have, right? And so it's been studied like crazy. Nobody wants a pancreatic fistula, but despite all these studies for the last several decades, basically we still don't know how to stop it. This is what we know is risk factors for a fistula: soft gland, small duct. We know that if you have these, your fistula rate is high. But despite knowing who are high risk, we can't decrease this fistula rate for decades to go. So we decided, let's see if computer vision can help us with this. So we basically built this tool to basically say, here are the people that we did the resections on, and these are people who got fistulas, and we did some unstructured learning and some reinforcement learning. And for once, we started seeing some things that we actually, despite the decades of learning, of studies, we've never really identified anywhere in the literature as risk factors for fistula. And these are things like this: staple line bleeding, capsular fracture, thinning by using energy, staple line bleeding fixed with a clip. And so even things like transecting the pancreas not perpendicularly as opposed to perpendicularly. Nobody, I've taught this surgery now in 5 continents. Nobody has ever talked about these things, and now we know that they are actually risk factors for fistula. And unlike these male high BMI, I can't help these things. I can't help if somebody is a male that has pancreas cancer, but guess what? I actually can help this. I can actually fix these, so they're actionable. And things like this, the coarse movement of the stapler during stapling. Nobody's ever talked about this, or versus fine. And now we know that this actually has a higher risk of fistula. Even things to like which way your stapler turns. If you move this up and down, it's actually less problematic than if you move your stapler side to side when you're stapling. Again, things that you can identify that we never really talked about before. And now, again, this is only our CT scans, our data. So now we have Cleveland, Miami, Dallas, and DC have all joined with us, and we're going to basically validate this with a bigger cohort. But as you could see, coarse movement fracture, a lot of things that we feel are much more actionable. So we're very excited about this. The last venture that we're doing in terms of computer vision, for again, this is for faculty, is the idea of like, can we actually help the surgeons when they're doing the procedure, right? And so the idea is guidance in the procedure. And this is again just for surgeons, but again, this can happen. The same idea can happen for any procedure. So we took a bunch of expert surgeons and we had them annotate during the gallbladder surgery to basically say where they would dissect or not. This is just 3 of us that annotated. We developed a deep neural network, and then we basically now use it to actually superimpose for surgeons when they're operating. So let me give you an example. So this is a computer looking at a gallbladder that it's never seen before. It's never seen this gallbladder, but it's able to identify the anatomy, obviously, really quickly, but then able to superimpose go versus no go. Go is green, no go is red, of where expert surgeons would operate, despite the fact that it's never actually seen this. And so now the surgeon, of course, they're still responsible. They can choose to follow it or not. But as you can see now, as this surgeon turns the gallbladder, within literally milliseconds, it's able to identify the anatomy and then superimpose on it where to dissect, where experts would dissect and where experts won't. Point being is that this is we're developing this to basically be kind of a really good like second opinion in the operating room, especially for surgeons who are operating by themselves or things like that. And this is kind of focused up here in that diagram of like the idea of like VBA and coaching interoperatively. Here's an example of a bile duct injury that we received that somebody did a bile duct injury a long time ago, and we took this computer. This video, and basically put the algorithm on this video. This is in retrospect, just to see if it works. And this is where this is the gallbladder. That's the liver in the back. The gallbladder is up here. The surgeon is operating on here. This is a heat map saying this is where expert surgeons would operate. Obviously, the surgeon is operating way off where most expert surgeons would operate. And you're going to see in a little bit, he's going to clip the duct here, and this is a common bile duct injury that's happening, despite the fact, it's happening in real, as we see it. And as you can see, the computer is able to recognize this, even in a bad video like this, and say, you should be up here, but the surgeon is down here. Now, imagine if this type of tool was present there, it would be very helpful in my mind to give them a second opinion. Anyway, so that's the kind of big picture. I just want to kind of point out that there's a lot changing, and the question always comes up is, what is a physician? Is it just what's in our skulls, or is it us plus computer vision, LLMs, that actually help us avoid mistakes, give us a second opinion? We know that at least in procedural medicine, that the most common reason for complication is misperception, us thinking we see something, but we're actually we're not seeing what we think we're seeing. And this is a perfect place for computer vision to say, hey, do you know that the ureter is there? I mean, if you know, that's fine, but I just want to make sure you. And the idea here behind this is, as we do procedures, we need to collect video, we need to annotate them, and this is now cheaper and easier than ever. It used to be that you would hire people to annotate, but now this is all done electronically. Develop algorithms, and this is kind of, in my mind, where we actually improve. And so this is my last slide, and the idea behind procedural medicine is that we need to, as a community, focus on visualization, verbalization, in the sense that we need better videos. We need people to be learners and surgeons and proceduralists to actually have access to good videos, to be able to say, hey, what's good and what's not good. And then we need, when we practice on reinforcement, we need to be able to get feedback and simulation, and asynchronous cloud-based feedback is, in my mind, the solution to this issue, because we've always known this is important, but we've never been able to do it because it's just too costly and nobody has the time to give feedback or coach. But this is all now done. It can be done via the cloud asynchronously. And then obviously for skills mastery and skills autonomy, while we like it when somebody achieves autonomy, it is important to also deconstruct autonomy to be able to get to expertise. And that's also something now that is easier, especially with a lot of the technology that we have. So with that, I'm going to stop, and I really appreciate you all being here and allowing me to present, and hopefully this was relevant, and I look forward to any questions. Thank you.
Thank you. That was great. And so interesting to hear, as somebody who's obviously not a surgeon, kind of what surgical training looks like behind the scenes, at least these days. Tying this into medical training, some of the more procedural specialties like critical care, line placement and things like that, are some of these more high-tech things that you were talking about with the AI, the like video overlay that you just showed. Is that being used in those specialties as well?
IR is really doing a lot of work on this. I mean, the whole point that a lot of times, if you look at a question and say, what does it require an expert in the field of IR or a procedurist in critical care or GI to actually do, and say like, how can I actually make the novice, or not novice, but like the junior faculty as good as the expert, or at least know? Yes, that's, I mean, to the point where you can actually have, for example, ultrasound guided central lines. There's no question now that we have technology that actually not only deciphers your anatomy, but also tells you when your needle is like the length, and tells you like things like how far deep you're supposed to go. Even now, there's ones that actually looks at proxies for pressure, how much pressure is in the vein, so that you can know what to expect when you make sure you're on an artery. So there's a lot of technology that's happening. The question is like, how do we actually get people not only to use it, but to know how to understand it?
Absolutely. And I hear this study discussed a lot, speaking of medical subspecialties, of the endoscopists who, there's an AI assistant that shows them where to find where the polyps are. And then they're really great endoscopists before they use the AI. But then when they get used to using that for a while and you take it away, then they no longer can do it as well autonomously. And I wonder kind of how you strike that balance in surgery.
Yeah, no, and we're actually working with that company because that company is very interested in actually going into the operating room. And we have actually a couple of prototypes that we're actually doing right now. But my point is there's a lot to deconstruct in that question. The way I think about it is that you have to consciously decide when it's okay to be de-skilled. And it sounds like a silly way to say it, but de-skilling is not a bad thing. De-skilling is bad when it's done erratically and not in a controlled fashion, and in a situation where people actually then really need that skill back. And so, we're all de-skilled from one thing or another. I never, some of us are non-skilled. I was never skilled on how to ride a horse or how to do this, and it's fine. At some point, it's okay. And so that's what we're trying to do in surgery. We're basically trying to say is like, what's low-hanging fruit, and what's something that actually is linked to a real problem that we have, instead of just doing it because it's fancy. So like, for example, the distal pancreatectomy, we have a very bad complication. So for that, can we actually get it to a point that it tells people intraoperatively, no, you're moving too much, or you're not perpendicular. So to me, that's more feedback as opposed to an issue with de-skilling. But it's a really good question, and I certainly don't claim to know the answer perfectly. But in my mind is that if we can link it to an outcome, especially an outcome that it's actually truly iatrogenic, that is based on what somebody's doing, in my mind, I would be fine to basically to say that somebody really needs this LLM or this computer vision to do it well. That's okay. That's an okay de-scaling as long as it results in a good outcome. What's not okay is a situation where, for example, even like forget about AI, like the use of robotics. A lot of times now people are so into using robotics that they're actually not able to operate without the robot. That is a problem. And the reason why is because there's no way you can scale robotics around the country, like especially with the cost it is right now. And that is an issue. So it's kind of a case-by-case basis, if that makes sense.
Yeah, and that I wondered about that too. I guess it's predates AI and things, but the robotic surgeries, are you running into people who no longer, if you need to convert to an open, they can't do that anymore?
This is not even a robotic specific problem, but I would tell you, this was like 7 years ago. We had a person that was transferred because this was not here, I was still in Seattle, because they needed an appendectomy, but the surgeon was not comfortable with an open appendectomy, and the patient has had a hostile abdomen, so they didn't want to go open. And so absolutely a big problem, no question about that.
Thank you.
Thank you for amazing talk. My brain is flying right now. Thinking about application to our medical folks and thinking about teaching, and as Allison mentioned, thinking about our procedural specialties in medicine. If they said, okay, I have this problem in interventional pulmonary or this problem in this space, and they wanted to start approaching creating something like it seems like you and your colleagues here have done so well. Like, what would be their first steps? How would they go ahead and try to produce something like you've done in their space?
Yeah, it's a great question. I think that this is, I'll tell you what it is for when you need video, but it's really true for anything. So you have to ask your question self is, what's the source of my data? Right. And then you need to get diversified data. Now, you don't have to get diversified data right away. Like what I showed you in the distal pancreatectomy, that's not diversified. That's just us. But at least to say, I'm going to just take my data. Now, data could be CAT scans, could be MRIs, could be ultrasound, could be video, could be even iPhone video. It doesn't matter. But get some data. Once you get some of that data, we are so blessed in UCSF in the sense that we have so many people who are in this field, whether it's the Center for Intelligent Imaging in Greenwich Hall in Mission Bay, or whether CPH, which is the Computational Precision Health group at Berkeley, that would love to collaborate, right? And that's, or us, and so then it becomes easy. And it used to be hard, or not hard, it used to be costly because you needed people to do temporal annotation, and then you need people to do semantic segmentation. But now, actually, all of that is algorithmic. It's kind of like before you used to know how to code. Now ChatGPT codes for you. It's the same thing. I mean, you still have to fix some things, but it's so much easier and cheaper. And that's where you get your data and you say, do I have a signal or not? So if you have a good question, it's really never been easier than before. Just make sure that you get your data. And obviously, if your data is CT scans or MRIs, then obviously that data is already there. There is CI2, which is the Center for Intelligent Imaging, is able to capture your data, work with you, and basically cleaning it up, de-identifying it, doing all of that stuff work. So it's mostly just work. I presented this, but this is absolutely not just us. This is really, like, we've learned so much from radiology. We've learned so much from Berkeley, and it just works much better than before. So, yeah.
So much. This might be a loaded question. Do you see a future where the robotic surgery is autonomous?
Yeah, it's a great question. So there is a gentleman in Berkeley. I'm forgetting his last name. I think it's Keith, but his first name, I think it's Keith, but his last name is Goldberg, and he's basically pretty much probably the most influential roboticists in Berkeley. And so we had a dinner together, and we were all talking, and I asked him exactly that question, and then he told me, he's like Adnan, I've been trying. He's like, I've been doing robotics since I was 14. He actually has like patents on like NASA products, and I mean, he's incredible. And he's like, I've been doing robotics since 14. I've been trying to develop a robot that basically takes things out of my dishwasher and puts in the dirty ones for the last 10 years, and I still can't get it right. So my point is, I don't think in our lifetime, this is what he says, and I agree with him. Obviously, he knows a lot more than I do. I think there's a lot of issues with it, but automating portions of the procedure, absolutely, it already happens, right? So the world of orthopedics has a lot more robotics than the world of soft tissue surgery. And in orthopedics, you can actually have a surgeon that actually plans the surgery and then like pushes a button, and a robot would do it better than them, for sure, because they're literally nanometer accuracy of placement that screw or the rod. I don't know anything about orthopedics, but as you could say, like incredible accuracy. So absolutely, that's automated. But the issue of like the planning and things like it becomes much more challenging. So autonomous for sure. Complete autonomous, I think there's a lot of challenges right now. I think that's not even our next hurdle. The next hurdle is actually telesurgery, teleprocedures, which basically means like, for example, in bronchoscopy in the field of medicine, you don't really need really, really, really good robots like the Monarch robot to do bronchoscopy. And so you can imagine if you have somebody in, kind of rural California who is not really an endoscopist, but is able to intubate the patient and put in the the monarch into the ET tube, and then basically somebody from here drives it all the way up, does the biopsy. That's doable today, 100%, you know? So that idea of how do we do it safely is really the next question we're trying to figure out. And we actually have a consensus conference in Istanbul on that in November. I don't know if we're going to get answers, but like that's already happening. I mean, there's a surgeon in Orlando, Florida, that has done like 100-something prostatectomies in India from Orlando, Florida. And is that appropriate? What happens if he gets into bleeding and there's, you know, and so that's already exploding, and that because of the ability of the technology, and there's a robot there and there's a console here. And that's really the next hurdle, I think.
Great. Another question over here.
Hi, Jordan Chan from Baker Institute and upcoming intern in medicine. So thank you so much for the speech. I would like to ask about how were the novel intra-op variables, for example, like horse versus fly movements, or like the side-to-side movement versus like vertical movements defined. Were those discovered by, you know, feature identification by AI, etc., or like those variables are actually defined by humans? Thank you so much.
That's a great question. Baker Institute is another, you know, great to your question, you know, an incredible resource for all of us. So in this situation, actually, this was unstructured learning. And it just basically told us that, hey, these patients, these things seem to be related. And because we really had no idea. I mean, if somebody had told me 5 years ago, oh, this movement results more fistulas than this movement, I was like, okay, well, that's your opinion. I don't know, right? But now we at least have a pilot that shows that that may be true. But if you look at all the thousands of papers written about it, that's never been described. And so, and I'm not saying we discovered it. Like the idea is that VBA, video-based assessment, now is allowing us to look at things that we've studied for decades and now look at them in a completely different face. So yeah. So we didn't define it. We didn't discover it, but we defined it after it was told to us. That's your question.
Great. One more question from online, which was thoughts about throwing a curveball into the sim work for the trainees when they're suturing or whatever, in terms of, you know, how they might do in flight simulation, just to make sure that they're, you know, ready for the real world.
It's a great idea. There's a lot of precedence to this. When I was studying simulation, I was studying a paper out of University of London, where in the anatomy simulation, they sometimes would put like a chimpanzee bone instead of a human bone to see if somebody would capture it. And so things like that. So it's a good idea. What we're trying to do, our curriculum is really not about judgment, as it is mostly about understanding the technology and getting, but if we were trying to teach more of a judgment thing, absolutely we'll do that. Yeah, makes sense. So.
Cool. We're at the hour, but thank you so much.
Thank you.